The next speaker is Gero Kramer, Professor Kramer. He will be talking on perspective on imaging.
Thank you for the invitation. So I've been asked to talk about the perspectives on imaging with a focus on PET and MRI. So what is in the next 24 months? And that's even hard to predict because it depends which imaging modalities do you have access to. But PSMA PET will stay in the focus in the next 24 months, also because it can be coupled with alpha and beta emitters and used as theragnostics. And you can also combine different imaging modalities that may help in selecting the best treatment option. So in this case, PSMA PET is a gatekeeper for the treatment of metastatic prostate cancer with radium-223. On the left graph, you see that in bone scans, you see nearly any lesions, but in a PSMA PET you see, and these patients respond bad to radium-223. And on the other side, if you have lesions in the bone scan confirmed by PSMA PET, these patients will respond well. So we have to continue to look if these PETs can help us in deciding which treatment we should use. And here we are at the next diagnostic, that's lutetium PSMA. And we are in Vienna, we are doing a very aggressive protocol with 3 cycles of 7.4 gigabecquerel. And you see on the right side the baseline of a patient with castration-resistant prostate cancer with a lot of liver metastasis and lymph node metastasis, and they have to be PSMA positive to be able to have a good treatment response to lutetium. And if you look at the data from Baum and our data, you have a partial response rate according to RECIST criteria up to 40%, which is pretty much. You can follow also these patients during different treatment regimens during castration-resistant prostate cancer, as you see here. But in fact, we have no data on that, no prospective trials, even not even retrospective studies dealing with monitoring in castration-resistant prostate cancer. This will change in the next 24 months, especially new protocols will be established. And this is actinium, and it seems to be even better than lutetium, though also here studies are lacking. You can also monitor patients during chemohormonal treatment. This is a PSMA PET of a patient with hormone-naive prostate cancer, and as you see, a good response in a PSMA PET, but currently we don't know what it really means, if it correlates to survival, if it correlates to progression-free survival. But what's interesting with the new diagnostic measures, and that's very important, seeing that we find early supraclavicular lymph node mets or lung mets in hormone-naive prostate cancer. This will change our view of the disease, change our view of biology. Probably we can, and we hear that afterwards, probably we can, based on that, build some new immunologic concepts on that, but studies are still needed. What I like most of the very few trials on whole body MRI in monitoring treatment response is the pilot study by Tunario's group showing that whole body MRI can be used as a treatment response biomarker. And here you see an example that an increase in the median ADC correlates with response. And of the 6 responders in the olaparib trial, all these responders showed an increase in ADC. If you make the working load a little bit lower, they tested up to 5 target lesions. There's also a central section of the 5 targets, and found out that a decrease in volume also is associated with a treatment response. So we have to build on these studies to probably find also radiological biomarkers for our treatments. And last but not least, we have to find association with PSA responses. What are the MRI signatures if a patient is primary resistant for ANSWER and abiraterone? And these studies are also ongoing, and I hope in the next 2 years we have a lot of more studies started and probably some new data. So to summarize, PET, we have an increased use of molecular imaging using specific PET traces. It may be the gatekeeper for radionuclide therapies, but value of treatment monitoring is in general still unknown. Better knowledge when and where new meds develop, that probably can lead to new therapeutic concepts, and whole body MRI could be a new response biomarker for bone meds. And I would argue for using more bone MRI in the future. Thank you very much.
Thank you, Gero. And I have to say that Gero is a urologist. So that was a very difficult task, but we couldn't decide if we get Stefano Fonti again or Anwar. And as you know, they're both a bit one-sided. So we have a urologist. So is there some questions from the panel to Gero or to Anwar or to Stefano, if they're still here? So I guess I start. I think we all of us who have really seen these treatments with PSMA, if it's lutetium, yttrium, or actinium, it's pretty amazing what sometimes happens. And I just wonder, what do you think, how will the studies been going, or do you know anything, what is planned?
I mean, we have very good results, especially regarding subjective response. So.
Thank you, Chuck. I'm surprised you didn't say anything about vaccination combined with immune checkpoint inhibitors.
You know, I was trying to keep within my allotted time, and I actually just realized. So I had a table of all these vaccines, and it turns out that there's two things. First of all, there's a whole number of unique vaccines. There's a DNA vaccine from a company called Inovio that targets several antigens. And there's these two really interesting listeria-based vaccines that are both in phase 1 and also in phase 2 combination trials. Those trials are ongoing, actually. They're phase 1 and phase 2 trials. Probably not likely to emerge as practice changing in 2 years, but we certainly will get data on their activity within the 2 years. Thanks for reminding me.
Hey, Chuck, great talk. So, of course, I'm really excited about all this stuff, particularly the MSI and mismatch repair deficiency, is particularly as a predictive biomarker for checkpoint blockade and immunotherapy. So, my question though is, I mentioned this in my talk. You know, it's not clear to me that traditional microsatellite instability methods that we've used for decades in colorectal cancer and to a lesser extent endometrial cancer are going to perform as well in prostate cancer. So it's extremely exciting that we're very near approval on the basis of MSI of these drugs, but the testing methodology, I think it becomes very urgent to start examining those questions, which we and others are doing, but it's actually, this is news to me that it may be coming. So my question to you is, do you think we should jump into this in the absence of having very, very good validation of those tests, that is MSI tests on prostate cancer?
It's a wonderful point, actually. So these large, and there are these two large basket trials use fairly rudimentary MSI tests. They don't use anywhere near the testing that you do by genomic sequencing level. So I think what's going to happen, this is and you could see if you agree or not. What I think is those tests probably underestimate the true incidence of MSI. You know, as you mentioned in your case series, you thought it was maybe as high as 9%. So I think that what will happen, honestly, though, clinically, is even if there's a couple of patients in that cohort, the drug will be able to be given, right? And then going forward, tests like yours that are really more accurate in predicting true MSI will become incredibly important. So like, work on it, man.
Yeah, that's a great point too. I think the problem is more false negatives and false positives, which isn't a bad problem in this setting. So that's a great point. One other quick point. So I know there's combo trials going on with checkpoint blockade and other inhibitors, PARP inhibitors in a number of contexts, including ovarian cancer. Can we learn from that setting in terms of your idea that, which would be very exciting if it's true, that maybe the homologous recombination DNA repair mutated guys also, that might be predictive of immunotherapy or checkpoint blockade?
It's funny you should say that, because like before the thing, like Chris elbowed me like this, and he said, hey, what do you think about these data? So, the NIH group presented data at GeoASCO showing the combination of durvalumab, the anti-PD-L1 antibody from AZ, with just happened to be AZ's PARP inhibitor. And when I asked them, like, what was the biological rationale, they said, well, they both came from AZ and they're right down the road, right? But actually, if you think about it a little bit more logically, they both might affect DNA damage repair patients, and they might there's a chance that the effects, the anti-tumor effects of PARP inhibitors could lead to an inflammatory response that could be magnified by anti-PD-L1. So there is, you could make up some sort of biological rationale for synergy. It was a small number of patients, that's why Chris was elbowing me, but I think it's actually a reasonable idea. And you saw that Merck is going to test that in their signal-seeking trial. So we'll see. I mean, I think it's a great point.
I hope it's true. It's exciting.
I have a question for you. Do you expect any improvement in the knowledge of combining radiotherapy and immunoagents?
Yeah, this is a great question. So in some animal models, you can do this great trick, actually. You give mice like 2 tumors, and then you give them some immunological stuff, right? And then you radiate one tumor, and the other tumor goes away, and that's an abscopal effect, and you're very proud of yourself. This has been like the experiment that's launched 1,000 ships. So there are literally at least 50 or 60 trials trying to induce this in patients, actually. And unfortunately, I mean, and radiation oncologists throughout the room could weigh in, but I think that if this was magic in patients, we would have seen it already. I think it's a little more complicated than that. One of the things that my lab has looked at, and I think I was talking to Dr. Roach about this too, actually. One thing is it looks like when you radiate tumors, the antigens are not presented in the tumor, they're presented in the draining lymph node. And so if you look at schemes that in animals, we model this, if you radiate the tumor and the draining lymph node, like we do sometimes in patients, you actually totally destroy any ability to combine or synergize with immunotherapy. So I think this is, maybe a subtle thing for immunologists, but not for radiation oncologists. So thinking forward, I think that there's a lot of ongoing trials, and we might see some magic, but we haven't so far. But we're hopeful that it can happen.